Hello and welcome to Group 1 Background Screening's second webinar in our series this year. Our webinar today is called Top 10 Things to Know About Drug Screening. I'm your host, Caitlin Ellis, the Marketing Coordinator at Group 1 Background Screening, and I have with me here our co-host, David Graves.
Hello, Caitlin. Hope you and everyone in our audience are staying safe as we all get through these uncertain times. Again, my name is David Graves, and I am the Business Sales Representative for Group 1. I am very happy to be here and looking forward to our presentation with i3 Screen. I will be talking again later in the broadcast near the end of the presentation during the question and answer time. So if our audience have any questions that arise during the presentation, you can simply just enter your questions or comments in the comments section at the bottom of the screen, and we will get to those asking our panel guests at the end of the presentation. So Caitlin, tell us a little bit about our guests that we have with us today from i3 Screen.
Yes, we have Dr. Janelle Jaworski, or as we like to call her, Dr. J. She is an MRO for i3 Screen. She's been an MRO for over 2 decades. She's been with i3 Screen for about 10 years. We also have John Gumina, who is the VP of Business Development. He's been with i3 Screen for 8 years and has a total of 27 years in the sales business. Welcome.
Thank you.
Thank you.
Janelle?
Yes.
Dr. Janelle?
Sorry. Yes, I'm
okay,
here.
Welcome to the show.
Thank you so much. Thank you for that introduction. We appreciate the time taken out of your day to help coordinate this webinar, and I'm very excited to share the information that we have.
Awesome. Yes, so our agenda here today, we'll be talking about birth of industry, drug screening testing cycle, types of testing, drugs tested, industry evolution, opioids, marijuana legalization, the challenges with the COVID-19, and then how Group 1 and i3 Screen collaborate together, and a little bit about our healthcare clients. So, Dr. J?
Thank you. To start off, lots of people wonder why we're doing testing in the first place. And the industry started over 30 years ago. In the mid-'80s, there was an executive order by President Reagan, and there was testing indicated for federally regulated employees. That didn't really go into effect much. There were laws that were being proposed and ideas. And in 1987, there was a train crash in Chase, Maryland, between Amtrak and Conrail. These two trains crashed. It was horrific, to say the least. And back in the day when testing did happen, it was usually through National Transportation Safety Bureau after the fact. There was no pre-hire testing that occurred. There was no random testing that occurred in the industry. But with these, in this and some other collisions and crashes and other events that occurred, whether it was rail or airway or with Federal Motor Carrier, it became the impetus to put laws into effect. And the mandatory urine drug testing was born. Go ahead, next slide. With that, the goal was established or attempted for a drug-free workplace in federally regulated employees. And the drug testing cycle was born. We call it a cycle. It goes in circles. It starts initially with the employer. And most employers that are federally regulated follow those federal regulations. Some employers may have non-regulated employees, and they may mirror that those federal regulations for non-regulated employees. So for instance, they may have people who drive trucks, but they may also have people who drive forklifts to load the trucks, and other people with a lot of other different industries that may or may not be transportation related at all. Employers need a policy. If they're following federal regulations, it's spelled out. There's about 380 pages of federal regulations that address testing. It's spelled out in black and white. If it's non-regulated, then policy may mirror that, or policies may differ in lots of different ways. Once an employer has a policy, then their employees need to have a sample collected. There has to be a collection site set up. They contract with a lab to do testing. They then become affiliated with an office like ours with an MRO who reviews testing that is non-negative, and then our results go back to the employer. The employer then goes back to their policy to take action or not with negative or positive results. Many employers work with a third-party administrator who can handle collection site information, labs, contracting with labs, and MRO work. Ultimately, in federally regulated testing, it's the employer's responsibility to be sure that everyone is following the regulations and that the policy is administered uniformly to have an effective program. And the MRO can help, certainly. We often are called with questions. How do we address this? How do we make sure that, what they have in their policy matches the testing panel, for example? And as regulations change, which they have through the years that I've been here, that the employer's panel and policy and events that occur match to go along with the regulations. So they're in compliance. Next slide. Can we go to the next slide? Excellent. So after the employer decides to hire an employee, pre-hire, or has an employee already in hire, random, perhaps post-accident, the employee needs to go to a collection site. And the collection site uses chain of custody that will allow the MRO to get the information back to that employer. There's different types of collection sites. Some are lab owned, some are preferred third party. Others can be local doctors' offices, hospitals, chiropractors' offices, some type of healthcare provider that's trained to do collections. All different types of places can do collections. It's not limited to a lab-owned collection site, but some are lab-owned, and then those labs have processes in place for the samples to get to the labs in a very timely fashion. Next slide. When collections are done, there's a form filled out. We call it a custody and control form. They can be a federal drug testing custody and control form or non-regulated. And the forms have a lot of information on them, whether that chain of custody is DOT or non-DOT. They have information to identify a specimen number, which would be unique for that lab. There's a place for a donor ID number. Some donors have a social security or last four of the social or an employee number, or in this day and age now with federal motor carrier, we often use driver's license numbers. So there's a way to identify that person, and there's barcodes used. Barcode technology is amazing to help match that specimen. The barcode goes on the the specimen itself on the tamper evident seal. And so there's a way to match that sample with that barcode and that specific specimen ID number. Years ago, everything was paper. There used to be a 7-page form with multiple copies. One went to the lab, one came to the MRO. There were others for the donor and the collection site. Now there are electronic forms that are available online, where ordering can be online. The donor comes in with a donor pass or a donor order, and the electronic CCF, a copy is printed, so the sample goes to the lab still with a piece of paper. And then other copies can go, for example, to us electronically or to the donor's email, so they still have a copy, but not necessarily a hard copy. Ordering that's done online is smooth and efficient, and it's amazing because then no one needs to lose a piece of paper, or that company knows when that was ordered, when the donor was given the donor pass, and whether they actually showed up or not. They can track all that information. Next slide. Currently, there are many certified labs. SAMHSA certifies labs, and many years ago there were almost 80 labs. It's closer to 26 now. There's one in Canada, but there are many very good labs. Some have multiple locations. For example, LabCorp has several locations. Quest has several locations across the country. So if a Quest sample is collected in Texas, for example, it can stay in and go to a certified lab location that's nearby. If it's North Carolina, it can stay right in North Carolina. And there's other locations across the country where travel time is cut down in an amazing fashion, because it doesn't take long at all if it starts here and it only has to go down the road a short distance. A certified lab is required for DOT testing. And at this point in time, DOT only uses urine testing. And for other types of testing, for example, hair testing, some employers may do hair and urine. Hair testing labs right now are not SAMHSA certified. I believe eventually down the road there will be standards set with urine and oral fluid and some of the other alternate processes. But right now those are not SAMHSA certified. Quest is a certified lab. They do hair testing, but that part of it is not SAMHSA certified. I believe that type of testing is very, very good. It gives a different window of detection, but for the time being, that's not SAMHSA certified. When the labs get a sample, they do primarily 2 different types of tests. A screening first. If the screening test is negative and the validity testing is within parameters for urine, then it's done. If its screen is negative, it's done. It's negative and it's sent. If the screening is positive in one or more categories, then there's a confirmation test, a separate confirmation testing using gas chromatography with mass spectrometry, or alternately liquid chromatography with tandem mass spectrometry. And the second test confirms the exact identity of what's showing in the sample. It can sort out the differences between codeine and hydrocodone, for example, or hydrocodone and oxycodone. And so the second confirmation test is run before anything goes any further. It doesn't come out of the lab as, well, maybe this is positive or maybe this screening is showing something. The confirmation test is finished first. Once that's done, then lab tests are sent to the MRO. We have electronic download capability set up with multiple labs across the country. And so it's a secure download. We're not waiting for something to come on the fax, or we're not waiting for a piece of paper to come in the mail with a result. It's an electronic download that's secure and very time efficient. Next slide. Okay. The MRO is separate from the labs. We're separate from the collection sites, and we're separate from the company. We're a third party. We're independent. We're impartial. So once an MRO gets a result, we can interpret those results. We're doctors, or by either MD, medical doctor, or osteopathic doctors, and are certified. The federal regulations require that we have training and take examinations, and we have to recertify. So as of July 1, I will be here 24 years with this company and other companies before this, and I've recertified many times. We receive the new books, the new updates, we take the exams, and we're required to pass those exams before we can do any work for DOT. And for DOT purposes, all results must be reported to an MRO. In several states, non-DOT programs require that same reporting to an MRO, and review happens through an MRO system, just like DOT. Not all states match that requirement. When we have results that are non-negative, the chain of custody paperwork is reviewed and passed through, but we don't need to speak with a donor on a non-negative result, or on a negative result. On non-negative results, we interview the donors. Non-negative results, something positive, something invalid, something rejected by the laboratory in some instances, we speak with the donors. So when those collectors are collecting samples a day or so earlier, it's important that they fill out the form correctly and legibly so we have a phone number. If it's an electronic form, it's beautiful because it's typed and we don't have to try and decipher somebody's penmanship on phone numbers. But we try to interview donors. We need a phone number to reach them, and we talk with them. We explain who we are. I'm a doctor that reviews drug testing. I need to ask you some questions. We identify them with the specimen ID or the donor ID, and we look and talk with them and explain what shows on the testing and look to confirm a legitimate reason. If someone has a legitimate and verifiable medical explanation for what shows, then they're not going to fail their test. So, for example, if someone has codeine and someone takes Tylenol 3 with codeine or a cough syrup with codeine and it's theirs, they're not going to fail a test. If someone says they take codeine and they got it at the bar on Saturday night, or they borrowed some from their grandma or auntie who saw that they were coughing or something, that's a medical explanation, but it's not legitimate, and it can't be verified in their name. So we talk with the donors and we give them the opportunity to explain to us when they have a reason for something showing. Next slide. There are many different reasons for testing. A lot of testing is pre-employment, before someone is hired, after or along the same time that a job offer is being made. Pre-employment testing is required in many industries. Once someone is hired, they may be part of a random pool. Random pools on DOT, there's specific percentages set for how many times someone in the random pool may be pulled, or how many they need for each quarter or each month, depending on the size of the company. Post-accident testing, defined by DOT regulations, is very specific incidents. If there's a fatality, if there's an accident requiring towing, if it's federal motor carrier. FAA, Federal Aviation Administration, has different definitions for accident. So it depends on which industry. Return to duty testing. very specifically, if someone has had a positive test in the past, has gone through an evaluation process with a substance abuse professional and done whatever program was recommended, they may come back to work, return to duty, in a DOT safety sensitive position. And then they may be subject to follow-up testing up to 5 years. Return to duty and follow-up testing is always an observed collection. The others are not. Post-hire testing is similar to pre-employment testing, but after an offer has been made for employment. Reasonable suspicion is spelled out, and this usually addresses behavior in the workplace. Someone is asleep and unrousable, or someone, for whatever reason, appears impaired at work, or especially in healthcare, someone was observed taking something from the med cart or that wasn't theirs and should have been going to a patient. Reasonable suspicion testing can be for multiple different reasons, but it's usually spelled out either in the regulations or in an employee policy. All these reasons can be an incident that causes a test to be collected. The MRO doesn't discuss usually with the donor why a sample was collected. If the company determined it needed to be collected, then it happened and we review it. If someone says, well, I really wasn't in the random pool, or it really wasn't an accident that required towing, that's not our determination to reconcile. That's up to the company. We review it, we report it to the company, and we instruct the donor to speak with the company about why the sample was collected and what truly is a correct reason or not. But the MRO doesn't get into the middle of why something was collected. If it happened and it's collected and it's tested, we'll review it. Next slide. Okay. For DOT purposes, we used to call it the standard 5-panel. And it's expanded through the years, but they still call it a 5-panel. Primarily marijuana, cocaine. In the amphetamine category, it used to be amphetamine and methamphetamine, but it's been expanded to include ecstasy, which is methylene dioxymethamphetamine, so it's a variant of methamphetamine, and methylene dioxyamphetamine. The opiate category originally contained codeine, morphine, and heroin. It's been expanded to include some synthetic opioids, hydrocodone, hydromorphone, oxycodone, oxymorphone. When hydrocodone breaks down, it creates the hydromorphone, or some people have a separate hydromorphone prescription. Oxycodone metabolizes to oxymorphone, or some people have a separate oxymorphone prescription. So those have been added in the not too recent past. And also phencyclidine, PCP. Next slide. For non-regulated testing, non-DOT testing, there's a standard 10-panel. It includes the other 5, and in addition, barbiturates, things like phenobarbital, which can be in multiple different medications, or butalbital, which is commonly used for headaches and migraines, are in the barbiturate category. It's considered a mild tranquilizer. Also, benzodiazepines, again, a mild tranquilizer, and might affect safety-sensitive function, or in some cases, any of these can be used or abused, and if there's not a legitimate medical explanation, then it makes sense for them to be on the panel. The benzodiazepine category includes things like Valium or Xanax. There are other benzodiazepines that can be used medically, short-acting drugs for procedures, like midazolam, and that can be used in the hospital. Not prescription type things, but can be used for example, a colonoscopy or a short procedure. Methadone is included in the 10 panel. Propoxyphene. Propoxyphene used to be is a brand name called Darvocet. It's been off the market since 2010, 10 years now, but amazingly, we still see it. And people have some source from some places, I'm not sure where, but we still see it, and it's still on many testing panels. Methaqualone, also called Quaaludes, remarkably sometimes is positive. It's not common, but it is on the testing panel, and it may explain sometimes reasonable suspicion behavior in some employees. Many other panels can be created depending on the industry. For example, in the healthcare industry, there are many other opioids that can be added to a testing panel that are not on the DOT panel. So it depends on what type of industry often, what the employer is looking for, and so panels are often available through the lab or can be created to suit the needs of that industry or that client. Next test, or next slide. Challenges of adulteration. This is a great topic. As soon as testing started, over 30 years ago, laboratories realized right away that some of the samples being sent may have been within temperature range at the time of the collection and may be yellow, but they were not urine. So lots of folks can look up on the internet how to beat a drug test. Lots of folks can buy products to add to their urine, or products to brew and drink this gallon of tea, or products and ways to hopefully not test positive for something they think might be in their system. In several states, Texas comes to mind right away, it's illegal to sell or use products to cheat on drug testing. So not all states have laws like that, but many do. Many steps have been taken in the industry to help prevent samples from being tested and passing a drug test that aren't actually urine. Specimen validity testing is testing on a sample. They look at lots of different things. They look at color, odor. If it smells like bleach, it can't be urine. But bleach could mess up testing, can mess up the screening test. Usually the collectors notice that right away. Urine doesn't smell like bleach, and it shouldn't, and therefore the collector will often immediately go to an observed collection for DOT purposes. When it gets to the lab, they check creatinine, specific gravity, pH, check for oxidant activity, lots of different parameters to help confirm that that yellow fluid in the cup is actually a urine sample. In other types of testing, for example, oral fluid testing, there are other parameters for validity testing, such as checking for IgG antibodies to be sure something that's in oral fluid is in the sample and it meets the parameters for that type of validity. Hair is hair. It's always observed. But through the years, I've had a few people tell me that it wasn't really their hair that was submitted. It was horse hair or it was dog hair or something else, which is always an interesting conversation. Different specimens may require different types of validity testing. So, for example, urine validity testing is definitely different than oral fluid validity testing. Next slide. For the different types of drugs that are tested, there's different answers that are being given by testing results. The timing of something showing in a sample is going to vary, whether it's urine or oral fluid or hair. The window of detection is drastically different. Oral fluid most closely reflects what's in the bloodstream. And so that window of detection is typically shorter for all items. And specifically for marijuana, oral fluid actually tests the parent THC and the THC metabolite. For urine, it's a metabolite. It's been in the body, it's been processed by the body enzymes and the body organs, and it's a metabolite. And so there's a difference in how long things may show up from the time they were used. And the window of detection for oral fluid is very, very short compared to hair, for example. Hair grows very slowly. Chemicals and drugs and medicines are deposited in hair as the hair grows. If something is used immediately right now, it may show up in oral fluid. It may show up in urine after a few hours. But it may not show up in hair for about a week until that hair has long enough to grow out. If it's something someone uses over time, then it may always be in the hair. But if it's a one or a very rare use over a few days or something, it will not show up in hair instantaneously like it would in oral fluid or urine collected later that day. So here's a chart that gives some different times of detection. Some drugs, they say, attached to the fat cells or fat-soluble drugs, and they may show up for a longer period of time. So, for example, THC, marijuana, and PCP is another one that's fat-soluble. Will show up for a longer period of time. Cocaine, amphetamines, opiates have a much shorter window of detection. In hair, it depends. Head hair grows out about a half an inch a month. So lots of people say, well, it always shows up for 3 months. That's assuming it's an 1.5 inch segment of hair and that it's at a high enough level to be detected in the sample. Sometimes people may use drugs that don't show up at all in hair because it may not be, or in any sample, because it may be there, but not at a high enough level to report over the cutoff. Okay, next slide. Okay. The evolution of testing. Through time, there have been changes. The federally regulated changes come slowly, but they've come around. Federally regulated testing is urine only at this time. Other types of testing, oral fluid and hair, have come about, and they're excellent. They are excellent for several reasons. One reason, they're observed. If someone is doing urine testing and they go in a different room, they close the door, or they close the door to the stall in the bathroom, and they come out with yellow fluid in a cup, it might be urine, but it might not. If someone is submitting an oral fluid sample, that person is there, their face is right in front of the collector, their identity has been confirmed, and that's an observed collection each and every time. And what's in them, in their oral fluid, is what goes in the sample, and not much else. We've had reports of people who say they were chewing gum, and the collector will confirm, nope, I told them to spit out the gum, and then we talked for about 10 or 15 minutes before that sample was collected. Or some people have read that if they suck on a penny or money, that it'll interfere with the testing, or different medicines that may interfere with the testing. But by the time someone gets in the collection site and talks with the collector long enough to fill out the form, their oral fluid changes over time. Everybody keeps swallowing. We don't pay attention to it, but we do. We swallow. And the oral fluid is truly representative, pretty close to what's in the bloodstream. Hair is also observed. It's a wonderful thing. It's observed. You know it came from that person. Collection facilities, there's lots and lots of places to provide samples. You don't have to go to only, years ago there were very limited, not very limited, but much more limited specimen collection sites. Lots of employers do their own collections. It's on site. Some employers have collection personnel come to the work site, so the employee doesn't have to leave work and potentially go somewhere else before they get to the collection site. So we have point of collection tests that are done often on site, and those personnel that can do on-site testing, then if anything does show, then it can be sent to a lab for confirmation testing. So there may be an initial test done at that site that is then sent on to a lab for confirmation testing. So the initial screening test isn't done at the lab, or it could be. Sometimes samples are collected both ways. That can be tested on site and then also screened again at the lab. Next slide. We now also have amazing computer systems where we have electronic solutions set up for the testing process to be handled. Human resources, it all starts there. Human resources can determine who needs testing, whether it's pre-hire or whatever the reason is. And this is something John Gumina can touch on later as well.
Yeah, do you want me to elaborate on this one, Dr. J?
That'd be great.
So, no problem. In this day and age, it's important for organizations of all types to have their drug testing results and information contained within the systems that they're using for the entire applicant experience or employee experience. So a lot of drug testing has been digitized over the years so that they can be integrated, and so you can get your drug testing results, place orders in HRIS systems, applicant tracking systems. Because of the advances over the last few years in the electronic custody and control form, so you don't need that 5-part paper form that's traditionally been used for drug testing. It's easy to integrate into the systems that your organization is going to be using on a daily basis. So, it facilitates pretty much all aspects of the process, from when you schedule an order to receiving status updates as certain milestones occur, as the donor goes to the collection site, as the specimen makes its way to the lab, as the MRO receives and adjudicates the specimen. You can get updates throughout that process. And then ultimately, at the end of the day, when the drug test result is adjudicated and released to the employer, it will also be released into these HRIS systems, or, people management software, I'll say. Next slide, please. So I'll continue to go on this, Dr. J,
Sure.
if you want.
Absolutely.
So I kind of just elaborated on some of this in what I just said, but thanks to digital collection methods, the use of these electronic custody and control forms, where everything is done using an online form essentially, and tracked electronically from all the points of the process, from the collection to the lab to the MRO to the employer. We can these methods are used at all those pieces of the puzzle. The collection site does it electronically. The laboratories predominantly the paper process can still be used, but these new advances are really streamlining the process, both in terms of the time that is spent, waiting for, when a test result comes through, but more importantly, just the visibility into the process that it provides the employers. So third-party administrators such as i3Screen and GroupOne what we do is we kind of serve as a conduit to all these different points of touch points, basically, for the process. So we'll connect you to the collection sites, as an employer, we connect you to the collection sites, the labs, the medical review officers. And also, we're integrated not only with these ATS and HRIS systems, but with your background screening platform as well. So, that's kind of another piece of the puzzle. Other pieces of software are also integrated with those. So it really, lends itself to a seamless process. Next slide, please. All right, now I'm going to turn it back to you, Dr. J.
Sure thing. Thanks. The opioid category, formerly called opiates, used to include codeine, morphine, and heroin. Opioids includes synthetic type medications that have been created and sold for many years now. Codeine is a painkiller. Morphine is a more powerful painkiller. Heroin is a drug that is only a drug of abuse. It can cause pain relief, but it is never used in the medical field. Hydrocodone is, so for example, going up a ladder, you might step at the bottom of the ladder is codeine. Going up the ladder, morphine. Closer to the top of the ladder is heroin. There are medical purposes for some opioids, and for heroin, there is no legitimate medical purpose. Hydrocodone is going up the ladder above codeine. Vicodin is a painkiller, and hydrocodone can also be in some cough syrups. Cough syrup can contain codeine. It can contain hydrocodone. These are all things that are on testing panels because they may be a possible safety concern. Even if someone has a prescription for some of these items, they're not going to fail their test. But for some industries and federally regulated industry, it may be a safety concern because on every one of these prescription bottle labels, it's going to say, may cause drowsiness, caution driving or operating machinery, or on some it says caution operating a vessel, a boat, airplane. And these are things that companies want to know. If someone has it and they pass, great. Or some companies want to know, is this a possible safety concern? And that's something we can set up with the company to help sort out that information. If someone has a prescription, they're not going to fail. Some people may have a prescription in their name and may have never taken the last couple pills and may use it at a later time. We can never tell for sure if there are other people who may have had a prescription but buy a baggie full of pills at the bar, so to speak, on Saturday night, and may have some other source of obtaining a prescription that's really not theirs, unless they're upfront and honest with us on the phone, which sometimes does not occur. We review all these different items. Dilaudid is a powerful narcotic. I remember years ago, my grandmother had very bad cancer, and it was spread through her body, and she was on Dilaudid. And but it can also be used in hospital settings. Oxycodone can be Percocet, short-acting, it can be OxyContin, long-acting, continuous release formulation of oxycodone that people may take only once every 24 hours or twice in 24 hours. And it's going to be in their system for a very long time at a more steady state level than if someone takes the short-acting medicine and it comes and goes within hours after it's used. Fentanyl is pretty close to the top of the ladder. There's a few others up there at the top of the ladder. This is a very, very potent narcotic. And there are formulations for IV use in the hospital, surgeries. There are formulations in a patch again, for someone who is terminal cancer and has horrible pain with the cancer, they may have a patch formulation where they put a patch on. There are other uses. There was a lollipop developed for people who, not sure why they couldn't wear a patch. Maybe they were allergic to the adhesive or something, but there was a lollipop developed even. This fentanyl is widely abused. It's been abused as long as fentanyl's been around. It's been widely abused, not only by healthcare providers who may have access to it and are diverting it in the healthcare system, or the other day I heard someone say, well, after Grandma passed away, I've been using her pain patches. Is that a problem? Okay, that's a problem. But these are all things, variation on the same theme of painkillers. They're used for pain relief, and they vary. Someone may not be sensitive to codeine at all. Other people are very, very sensitive and get very drowsy, only take their cough syrup at night before they go to bed, for example. They all have potential for abuse, and this is one of the reasons, primarily when testing started, what do we look for? What don't we want in the workplace? We and everybody agreed they don't want heroin. They want people who are using heroin currently to be at the job because there's potential for disaster. It's a very broad category, but it's very important that these items or similar items in this category be tested to help deter improper use of medications, if possible, or deter people working who may be impaired by their medication. Next slide. As we've all heard for many years now, these types of medicines are addictive. Whether it's heroin or codeine, people who take these types of chemicals build up a tolerance over time. And for heroin users, that may mean that they need more over time to get the same rush, to get the same effect. For codeine, if it's arthritis in my left knee, for example, what used to work years ago may not work very well right now because I've been using it for a while or someone uses it for a while. And people build up tolerance and may need more dose or a different drug to get the kind of relief for pain or to get the other abusive effect. In this country, millions of people suffer from addiction from this type of medication. In other countries as well, just everywhere. It's a problem throughout the world. Every 19 minutes, someone dies from an overdose. And the overdose can be Vicodin, it could be heroin laced with fentanyl. There's a lot of fatalities and morbidity to addiction. The statistics show that there are more deaths from opioids than car accidents. There may be some cases where that's together, but the number of deaths from opioids is horrendous. Can't even think of a good word right now. Horrendous. Years ago, there were over 650,000 prescriptions written per day for opioids. The number, there's been a lot, and through the last several years, as a doctor, there are training programs going on in every state to help doctors learn how to prescribe opioids more cautiously and in a manner that helps, in some ways, decrease this number. Next slide. The problem is if doctors decrease prescription use, sometimes people choose other sources of an opioid. It may lead to heroin use or use of other street drugs. Unfortunately, fentanyl is easy to manufacture, it's cheap to manufacture, it's extremely potent. There are places, I won't even qualify it as laboratories, there are places in China where fentanyl is being produced in old warehouses and other places not in a pharmaceutical grade production facility where fentanyl is produced and shows up here easily in this country. And it's not pure. There's no stringent production requirements like our pharmaceutical industry requires in this country, but it gets here and it goes for a lot of money. Drug dealers are finding this is often cheaper and easier than dealing heroin. And many times heroin is laced with fentanyl, and users don't even necessarily know that, which can often lead to overdoses because the drug potency is not regulated at all. So people who may be using what they think is heroin may have fentanyl in it, may not realize how much is in it or have no idea how potent it is, and can easily overdose without intentionally overdosing, but it happens. Next slide. So employers need to pay attention, I believe. It needs to be in the testing program. Some people, if they want to keep a job and understand that they're part of a testing program, they had a pre-employment test in the beginning, they know there's random testing, they know there's post-accident testing. People who want to keep a job, this may be a deterrent to use. And this has been borne out with DOT testing. Historically, the positivity rates for DOT employees run lower than non-DOT testing. So some industries, I remember years ago someone said the construction industry, for example, had higher testing positive rates than truck driving or Federal Aviation Administration, pilots and flight attendants and other people in the flight industry. So there is a deterrent value for people who know that their industry requires testing. It's not going to stop everyone. Everyone has free will. Everyone has a choice to make. It's not going to stop everyone. But for someone who understands, we just had a 3-day weekend, and Monday comes around, I might get tested, or Monday was the third day. Tuesday, I might get tested at work. I better not do this. Or everybody over there is smoking that. I won't do that because Tuesday I might get tested. I don't want to lose my job. There's a deterrence value. Companies that have testing programs has a policy. What's going to happen after a positive? Some companies terminate. That's it. That's done. Some companies allow an employee assistance program. One time through, I call it the revolving door, but it's probably a bad term. One time through, and once you hit it the second time, then there may be no more employment. DOT purposes, people are pulled out of safety sensitive duty if they have a failed test, if they have a positive test. So, but if they get pulled out of duty, they can participate in a substance abuse professional evaluation, an SAP, or employee assistance program, and they may potentially return back to that type of safety sensitive work. Depends on the industry. For FAA, Federal Aviation Administration, if there are 2 positives, they have what's called the Death Star rule. You never return to that type of work ever again for FAA. So if a pilot or some other FAA covered employees have 2 positives, that's it, they're done. And I've seen a few of those cases go to arbitration and union hearings and things like that, and it stands. That's the industry. You know those are the regulations. One time, you might come back. Second time, nope, doesn't happen. So it all depends. DOT has also set up, Federal Motor Carrier has also set up a clearinghouse that started earlier this year, where all positives get reported into that clearinghouse system. And all employers have to check that system for pre-employment reasons and for different reasons throughout the employment of an individual. And so there are ways to check so people can't just bounce around from one company to another without that being discovered. EAP programs are very important. There may be some very, very good employees who make a bad choice, whether it's a 3-day weekend or not, and they may have the opportunity to not lose their job if they follow through with the requirements of the EAP program. Depends on the employer, depends on their policy. Next up, marijuana. These numbers change periodically. Years ago, California was one of the first ones that said we're going to legalize marijuana for medical purposes. Our doctors can make a recommendation for marijuana use for medical purposes. And the laws in many other states have followed suit. Also, there may be recreational use. Again, this is where company policy is critical. You need to address whether you accept it or not, and if you don't, what are the consequences? Next slide. For DOT purposes, this is not accepted. It's just not. It's reported as positive, and then people address it with their company. Next slide. John, COVID-19.
All right. Thanks, Dr. J. That was great. So in terms of more very recent times, COVID-19 has not really had an impact on drug screening as a whole. There have been a few small impacts, especially early in the crisis where everybody was staying home, where some of the collection sites closed down. As employees stayed home and stayed in place. But now we're back to pretty much where we were beforehand, where we've got thousands of places across the country where you can go get your drug test collections done. The labs are operating. We are operating as an MRO and a TPA. That's basically how it's disrupted the network or processing times. One other question that may come up as it pertains to COVID-19 is, are companies like i3Screen or GroupOne going to be offering COVID-19 testing? And the short answer is probably, but there's a lot to be learned at this point. One of the biggest questions, drug testing and other occupational health screening services are not subject to HIPAA regulations because they're specific to somebody's employment. However, once we start getting into COVID-19 testing, it becomes a personal health record. So one of the things that we're trying to figure out is how do employers get the results of these COVID-19 tests? Are they something that can be stored in a system like ours? It may be, but we don't know how that's going to work yet. Or is it going to be something where the employee has the lock and key on that particular piece of information and they can distribute it as they see fit to employers? So Long story short, there's a lot of stuff that we need to learn in terms of COVID-19 testing in the workplace. But we're hopeful that that'll start to take shape in the next month or two. Next slide, please. All right. Basically, GroupOne and i3Screen are integrated partners. So i3Screen kind of serves as a back office to GroupOne when it comes to drug and other occupational health screening services. And what we're doing with GroupOne is to try to provide a solution where all of your vetting processes are in one place. You want to have a provider like GroupOne that can provide background tests or background checks and drug screens in one place, maybe other services as well. So in terms of drug testing, if your employees have a negative test, we will get that back to you within 24 hours of that sample being received at the lab. Usually that's going to mean the next morning you'll have a negative test result for a lab-based test. If a drug test does need to go to a medical review process, an adjudication process like Dr. J spoke about earlier, we usually will get on average, the vast majority of tests will be adjudicated and released to the employer within 72 hours of their receipt at the lab. And that includes the time to screen and confirm the sample, and then also the time it takes for Dr. J and her team to contact the donors and learn what they might have a prescription for, et cetera. So next slide. All right, I'm going to turn it over to David here for this one.
Thank you, John, and thank you, Dr. J, both of you. Very helpful information today that you both have shared with us. We at GroupOne, we really appreciate the relationship that we've developed over the years with i3Screen. Our clients have really grown to appreciate you guys and expect the high quality of service that you and your team have provided and made it possible for GroupOne to offer, great drug screening, fast drug screening with accurate results. So we really appreciate you and i3Screen. As many of you know, and many of the people on the audience right now are clients in the healthcare industry, and the expertise and industry-related experience that i3Screen brings to the table is just priceless to all of our clients. So thank you again, John and Dr. J, for sharing with us today the top 10 things we all need to know about drug screening. And just in closing, that's fine. I think everybody learned something hopefully today that was interesting. By the way, I'm going to do the question and answers in just a moment. So if you do have some questions, go ahead and start sending those questions in. We've already gotten a few in so far here. But also I've put up this contact slide for you. If during the presentation today you may already be a client of GroupOne and don't have drug screening currently, here's my contact information, also Caitlin. Feel free to give us a call. And then we've also got i3Screen's information up here as well. So if you have more of a technical question that maybe you'd be more comfortable to ask them directly, there's Janelle's phone number and then also John's information as well. Now we'd like to turn it over to the question and answer time. So I'll let John, either you or Dr. J, jump in for the answers to these questions. We've got here the first question coming in. Person says, typically it takes about 24 hours for their drug screen results to come back either positive or negative, typically. But occasionally it takes longer when an MRO is reviewing the results. They want to know, why does it take longer in those cases, and what exactly is the MRO looking at when they're reviewing the results?
I can handle this one. This is easy. Typically, I like the word typically. That's a great word. Results, first of all, take the lab longer to send to us when it's positive. If a test is screening negative and the validity testing is okay, we get a negative pretty quickly. If it's positive, they have to go to that second confirmation test. In some instances, depending on how many things screen positive, the confirmation testing may be run in several categories. So first of all, it takes longer at the lab. Then we need to call the donor. Hopefully they answer. About half the time they do, half the time they don't, half the time they call back. It takes time to get a hold of the donor. And then we talk with the donor and explain to them what shows and what we need to review. If it's prescription medication, we can verify that very quickly, confirm it's filled in their name and filled before the test. So it takes time to talk to the donors. Sometimes people say they had surgery the day before the test and they were given fentanyl in surgery, or they had a colonoscopy and they were given Valium or some other sedative so they wouldn't be awake for their colonoscopy. And then they need to they need to sign a release and actually have the facility send us records. So it takes time for all those steps to occur. And then we look at the records and be sure it's actually real. We have hundreds of instances of records that have been altered or changed, or people take pictures of their pill bottles, but it's really not theirs, or the label's been changed. So we also have to look at what we receive to be sure it's authentic and accurate. So those are the reasons it takes more time when we're reviewing something. We want to make sure the result we send is actually the correct result. And we don't just skim through things and not scrutinize it a little bit, at least, to be sure that what we're getting from that person about that record or prescription is actually real. So it's just to be sure that you're getting the best result that's correct.
Very good. And we get the same kind of response when it comes to background screening as well. And we're always making sure that we're going to provide the clients with the very best accurate information. So we really appreciate the deep attention to detail. Another question coming in here is, considering the current COVID-19 situation, and John, you may have handled this question a little bit, but you might touch on it a little more. Are you seeing any slowdowns with drug screening due to the increased traffic going through drug screening labs to be tested for COVID-19?
We really are not being affected by that because, these COVID-19s are more of a clinical test rather than a toxicology test. So it's kind of a different wing of the laboratory. We did, as I mentioned before, we did see a little slowdown just when everything was closed down. That some of the collection sites did not have the staffing to get things done. But assuming that there's not a second wave where they close everything down, we don't anticipate that there'll be any issues pertaining to the drug testing and other occupational health screening services going forward.
Very good. We got another question here. We'll probably take one or two more. This is a funny way they phrase this question. Are there ways for a drug screening candidate to circumvent the system or study, in quotation marks, for a drug test? And then what are some ways i3 Screen ensures that the results are not watered down or a sample is replaced with a clean sample?
This is a great question, because so long as there's testing, there may be someone who tries to figure out a way to get around it. And that's why earlier I touched on the specimen validity testing. The laboratories check to see if a sample is dilute or not, and there are specific numbers set to determine and for the laboratory to report whether a sample is dilute or not. And then companies can address in their policy whether or not they accept a negative dilute sample. Many companies immediately recollect a negative dilute sample. There are reasons people drink a lot of fluid. Some people have gout and they want to get rid of the gout and they drink a lot of fluid. Some people drink a lot of fluid because they smoked something over the weekend that they're afraid may show up in their drug test. Or they bought a magic cleansing tea product, something, or through GNC or wherever, that's guaranteed to clean their system. And primarily the main ingredient is the gallon of water you brew it in or drink along with those 18 pills or whatever. So if a sample is dilute, companies should note that and probably should not ignore it. I had a company years ago who said, we recollect all our negative dilutes, and after looking at it for 2 years, half of the recollections came back positive for a drug that could not be explained. To me, that's a good reason to recollect all your negative dilutes. Something was going on. Another way to study for a drug test is to stop using for a while. That's handy.
Imagine that.
I worried about it a long time ago. If people really stop using drugs that aren't theirs, I might have to go back to forensic pathology. I'm not there yet, so I don't know that that will ever happen. That type of studying isn't happening. Replacing a sample, if the collector needs to be on task. The collectors, and they're trained, they need to pay attention to the temperature, they need to pay attention to the color. If it looks like Mountain Dew, it's probably Mountain Dew. It's not, it may be warm, but it's not urine. They need to pay attention to odor. You know, if something smells like bleach or something smells like soap, then the collectors need to be on task with that end of it. Will we ever be able to stop all of that? Probably not. But if all of us together and the validity testing are in place, I think we catch quite a bit of it, or we stop quite a bit of it.
Very good. Well, I think that's all the time we have here today. Thank you once again, John and Dr. J, for being with us today. We really appreciate the time you spent and the thoroughness in the presentation. Caitlin, I think you have a few closing words for us.
Yes, just want to say that this
quickly, thank you everybody from us too.
Great,
Awesome.
yes.
Thank you.
The information and opinions expressed are for educational purposes only and are based on current practice, industry-related knowledge, and business expertise. The information provided shall not be construed as legal advice, expressed, or implied.
We just want to make sure everybody is aware of that. And we really appreciate everybody and look forward to the next time we do the next presentation.
Thank you all.
Thanks so much.
Thank you.
Have a great day. Bye.
Thank you.